Welcome. Thanks for checking out this video. Today we're going to talk about drug treatment of the average patient. I'm going to explain why it's challenging, and I'm going to give you a simple algorithm that I hope would be useful that you may be able to adapt to your own context. Thanks for checking this out. This is a technical video that is intended mostly for prescribers of blood pressure lowering medication. My intention with all my videos is that they be accessible for anyone who might be interested in the topic. So if you are a patient and you are wondering why your doctor chooses one medication over another for treating your blood pressure, this video may be of interest to you, but I am using some medical lingo. And I hope that doesn't dissuade you from taking a look if you're in that category. If you're a prescriber, you should be able to follow all of the lingo that I use in this video very easily. This video is intended to inform you about my personal decision-making process. I do not intend that this video give you guidance in the individual case. I am not making therapeutic recommendations based on individual cases in this video. Specific recommendations depend on drug licensing authorities, which vary from place to place. And so obviously I can't make universal recommendations about what drug to use in what context. If you're concerned about your blood pressure and you think you may need medication or you may need a change in your medication, then you need to go see your doctor. This information reflects the scientific literature when it was produced, which is 2020. This may not be accurate in 1 year, 5 years, 10 years. We believe that scientific medical literature updates itself about every 10 years so that half of what we know and half of what theoretically could be in this video may be changed within 10 years. We'll talk about that at the end when I talk about what I'm going to do with comments from the video. I hope you enjoy this. The trouble with prescribing medications for patients who need them is that the average patient with high blood pressure doesn't require just one medication. The literature would suggest that the average patient requires 3 medications. So you can see in our little schematic illustrated on this slide that we always start with healthy living, and some of the other videos will talk about that. And then if you think about the process for initiating 3 medications to lower blood pressure, in a scenario where we may have 5 different drug classes to choose from, the interesting question to ask yourself is, how many possibilities are there for you to choose from when you're picking those agents? In order to figure this out, you have to look at your grade 10 permutations and combinations math textbook. If you restrict yourself to 5 classes of drugs and assume that there's perhaps 2 doses available in each class, then there are 80 combinations of medication that you could choose from that would adequately provide 3 medications. Now, if you're the kind of person that cares about the order that you use these medications, so you want the diuretic first and then you want the RAS blocker, then there are about 500 ways that a 3-drug cocktail can be set up. The specifics will vary from jurisdiction to jurisdiction. I happen to work in Ontario and Canada, and I've pulled up the Ontario Provincial Drug Formulary for this analysis of how many options there would be to provide 3 medications for a patient that I wanted to treat for high blood pressure. And I have only looked at options here that make scientific sense. I have not looked at things like a combination of an ACE inhibitor and an ARB together. I have not looked at combinations of 2 of the same type of diuretic. These are legitimate combinations that have been studied in scientific studies of hypertension. Based on the formulary that I have access to, we have diuretics, we have beta blockers, we have ACE inhibitors, we have angiotensin receptor blockers, and we have calcium channel blockers. Within each of those classes, there are 7 diuretics, 10 beta blockers, 10 ACE inhibitors, 7 angiotensin receptor blockers, and 5 calcium channel blockers that could be chosen from. In scenario A, where we have only 1 dose per drug, and we don't care about the order of initiation, there are about 3,000 combinations of medications that we could be putting a patient on to lower their blood pressure. If we look at scenario B, where we have 2 doses, and that's a more realistic possibility, a low dose and a medium dose, for example, and we still don't care about the order of initiation, we now have about 40,000 different combinations. If you're the kind of person, again, that cares about the order of initiation, you want the diuretic before the RAS blocker or vice versa, now you're up to about 250,000 options for how you could treat a patient with high blood pressure. And this is simply the average patient who requires 3 medications. This is a disaster for the prescribing of drug therapies for patients with high blood pressure. Having too much choice, having too much complexity leads to therapeutic inertia. There are so many choices we don't know what to choose, and so we just avoid the decision. And often we make errors because there's just too many options to consider when we are deciding what to use. And that is why we need a simple algorithm for how we initiate drug therapy in these patients. What I want to propose for you in this video is a simple algorithm that can help to guide decision making when you are establishing an effective combination of medications to use in your average patient with high blood pressure. Now, part of the reason I'm using this word average is that this video is not intended for patients who have a specific reason to use a specific drug. So for example, if a patient has heart failure, then you're going to need them on an afterload reducing drug. You're going to need them on an ACE inhibitor or an angiotensin receptor blocker, and there's no question about that. If a patient has ischemic heart disease, you will often be using beta blockers preferentially in that scenario. If a patient has a low renin state, they have adrenal hyperplasia with hyperaldosteronism, you may start that patient with spironolactone. This video is not talking about that patient. This video is talking about the average patient without a compelling reason for any one particular treatment over another. The first step in my personal algorithm is I'm thinking about adding a RAS inhibiting drug, a drug that blocks the renin-angiotensin system. And basically I'm going to choose between an ACE inhibitor or an angiotensin receptor blocker. The way I make that choice is I think about what the odds that the patient will end up complaining of cough while they're on treatment. If the odds are high, then I'm going to use an angiotensin receptor blocker. If the odds are low, I'm usually going to go with an ACE inhibitor. Some common reasons to believe a patient might cough would be that they coughed before when they were taking an ACE inhibitor. If the patient has a pre-existing reason for cough, so for example, they have dyspepsia with gastroesophageal reflux, if they have asthma, they have chronic obstructive pulmonary disease, or they present to your office and they're already coughing while you're seeing them, then that patient is the kind of patient I would steer towards taking an angiotensin receptor blocker first rather than an ACE inhibitor. If the patient doesn't have those reasons, or perhaps a genetic reason to have a cough from an ACE inhibitor, then I would normally give them an ACE inhibitor. The second step in the treatment algorithm that I use is what I call synergy and side effects. I'm trying to give patients drugs that I know will be very synergistic with the RAS inhibiting drug to lower blood pressure, but it will also help to mitigate side effects. So in general, as add-on therapy in stage 2, our choice is either diuretics or calcium channel blockers. For the diuretics, I prefer thiazide-like diuretics as opposed to thiazide diuretics because I prefer the longer half-life associated with drugs like indapamide or chlorthalidone. For the calcium channel blockers, I prefer dihydropyridine calcium channel blockers such as amlodipine, nifedipine, or felodipine. The first factor that I look at when I'm trying to decide which of these agents I should be giving as the second drug in the drug cocktail is I look at volume status. I look at whether the patient is puffy and has, for example, pedal edema, or whether they're more on the dry side and do not have pedal edema. A patient that has pedal edema, I might steer towards a diuretic-based second step. If the patient doesn't have any pedal edema, then I'm going to give them a calcium channel blocker as the second step. And as you can see illustrated in my graphic, I prefer calcium channel blockers. More of the patients in my diagram are getting calcium channel blockers than diuretics in stage 2 of the treatment algorithm. The other factor that mitigates my choice is the serum potassium level. So after I have placed a patient on a RAS blocking agent, if their potassium levels are higher, that would be another reason I might consider the diuretic-based strategy. If the potassium level is normal, maybe up to 4.5, even 4.7 or so millimoles per liter, then I'm going to give them the calcium channel blocker as stage 2. Otherwise, they may get a thiazide-like diuretic. In this slide, we've got step 1, which is basically a decision made on the probability of cough. Stage 2 is either the patient ends up on, I'll just look at the ACE inhibitor side of the diagram, they either end up on their ACE inhibitor with a calcium channel blocker, or they end up on their ACE inhibitor with a diuretic. In many jurisdictions around the world, these agents are available in single pill combination, which makes things quite handy. So now, what do you do next? Well, step 3 is that we consider adding on the drug that we didn't add on in step 2. So in step 2, if we added the calcium channel blocker, then in step 3 we're likely to give them the diuretic. And vice versa. If a patient was given a diuretic in step 2, perhaps because they had a little bit of edema, then in step 3, once we've got their edema under control with our diuretic, then we will look at introducing the calcium channel blocker in step 3. So the average patient that I see that ends up requiring 3 medications, obviously you wouldn't give them 3 if they had already achieved target blood pressure in step 2, but assuming they don't and they need 3 medications, then in step 3 they're going to be on a RAS blocking drug, they're going to be on a calcium channel blocker, and they're going to be on a thiazide-like diuretic. Step 4 is where things get really interesting. We basically have 3 options to consider for step 4. We have spironolactone, which is a mineralocorticoid antagonist. We have doxazosin, which is an alpha-1 receptor antagonist. And then we have beta blockers, which are generally beta-1 specific beta adrenergic blocking agents. What you can see first in my graphic is that most patients for step 4, for the 4th drug in the algorithm, assuming they need a 4th drug, will end up on spironolactone. The second most common 4th drug that I would use in my practice are beta blockers, and then the third most common 4th drug is doxazosin. So how do I decide which of these 3 drugs to give a patient? Well, the first thing I look at is the serum potassium level. If the serum potassium level is not high, then the patient is going to get spironolactone. If the potassium level is very high, above 4.5, that's where I'm going to consider using either a beta blocker or doxazosin. In terms of deciding between those 2 agents, the decision making is really related to heart rate. If a patient has a heart rate that is above 60 beats per minute, perhaps 70, then I will steer them towards using a beta blocker as the 4th drug, assuming that they're not a candidate for spironolactone. If their heart rate is less than 60, that's where I'm considering doxazosin, in some cases less than 70, as my 4th drug in the 4-drug cocktail. So this is what the schematic looks like. You have a patient who's taking 3 agents, an ACE, a CCB, and a diuretic. They then go through the decision making around a 4th drug because their blood pressures are still not at target, and the largest proportion of patients will end up on a 4-drug cocktail that includes a RAS blocker, in my illustration an ACE inhibitor, with spironolactone, calcium channel blocker, and the diuretic. A smaller proportion will end up on the ACE inhibitor, beta blocker, calcium channel blocker, and diuretic. And then a smaller yet proportion will end up on ACE inhibitor, doxazosin, calcium channel blocker, and diuretic. So you have your patient on these 4 medications, you've got it at a reasonable dose, and the patient's blood pressure is still not at target. What do you do in step 5? It's worthwhile taking a step back and saying that this 4-drug cocktail is about 95% effective at controlling blood pressures in the average patient. And so if your patient is not achieving average, either they're a very exceptional patient or they're simply not taking their medication. And in many studies that have been done, it turns out that the answer is that they are simply not taking their medications. So before you move on and consider other drug therapy, you need to verify that the patient is actually taking the drugs you've prescribed. I do this using direct observed therapy. So I bring the patient into my clinic and I hook up an ambulatory blood pressure monitor that they can wear. I directly observe them taking the 4 agents that I have prescribed, and then I monitor carefully their blood pressure over a 4 to 6 hour period of time to verify that in fact they are taking their medications and that they are not getting an adequate blood pressure response after I directly observe them taking their medications. At all steps in this process, it is very important that you help your patient adhere to their therapy. And we'll talk about that a little more in a second. Once you've verified that the patient is in fact using all 4 of their medications appropriately, the next step in the process is to try to get them on more diuretic. I decide on how to escalate diuretic therapy based on serum potassium and kidney function. If their kidney function is off, then you may need to shift into an algorithm that's more appropriate for patients with renal impairment in general, and there will be another video about that. Assuming that their renal function is adequate, then I look at potassium level. If the potassium level is above, for example, 3.7 millimoles per liter, then I would be giving that patient more thiazide-like diuretic. If the potassium level is lower than 3.7, that's where I would normally try to intensify the spironolactone dosing to try to get the potassium level back up into a more normal range for my next step in the algorithm. Once I've got them going with an appropriate dose of spironolactone for further decision making about adding additional agents, I go back to this schematic, and this is where I'm considering, presumably my patient already on 4 agents is on spironolactone. They may be on a bigger dose of thiazide-like diuretic now. And so really the decision making is again about using a beta blocker as a 5th drug or doxazosin. And what I look at in that scenario is just heart rate. If their heart rate is on the higher side, above, for example, 70 beats per minute, then I might be more steered towards using a beta blocker. If the heart rate is on the lower side, that's where I may want to introduce doxazosin as the next drug in the cocktail. It's worthwhile taking a step back at this stage and saying that there are some things that we need to do very carefully in order to use antihypertensive medications safely. The most important thing when you are initiating, up-titrating, or adding antihypertensive medications is that you monitor your patient carefully for their symptoms. Symptoms matter most, especially in the first 2 to 4 weeks of therapy. Some of these agents take a little while to accumulate a blood pressure lowering effect. Some of them work very quickly, but for example, thiazide-like diuretics may take up to 3 weeks to achieve a blood pressure lowering. And so this is the time frame where you need to be able to have bidirectional transactions, communication with your patient, so that if they are experiencing symptoms, for example, dizziness when they stand up, you need to be able to respond to that appropriately. The second thing that you need to be able to do if you want to do this successfully and safely is that you need to be able to monitor blood pressure at home. Preferably with a home blood pressure monitor, if not ambulatory blood pressure monitoring is possible. Again, the time frame, when I talk to patients about measuring home blood pressures, anytime I make an adjustment in antihypertensive drug therapy, I ask them to monitor for somewhere between 1 to 3 weeks until we can see what the accumulated effect of my changes are. If you can't monitor blood pressure successfully, you're going to have a lot of trouble doing this algorithm safely. Another thing that you need to be able to do is assess blood pressure in a standing position after the patient has been on the drug therapy an adequate period of time. Now, the symptoms may drive your decision making about getting some standing blood pressures done, but you need to be able to do this if you're going to do this effectively. In most drug treatment trials where there was significant up-titration of drug therapy, the decision making was guided in part by the standing blood pressure, not just the sitting blood pressure, and certainly not supine blood pressure readings. The final thing, and this may be perhaps the most important thing to get right, is that after you add a drug that interferes with the renin-angiotensin system or renal function directly, you need to monitor that with blood testing. So after adding an ACE inhibitor, an ARB, a diuretic, spironolactone, you need to give the patient a requisition to check their sodium level, their potassium level, and their serum creatinine. And the time frame for when to check the blood work after a change in drug therapy is anywhere between 1 to 4 weeks, depending on the patient's scenario. And again, this is why I can't provide specific recommendations to specific cases, because it will vary. If I have a patient with tenuous renal function, perhaps with a potassium level that's on the high side of 4.5 millimoles per liter, I'm going to be rechecking that patient's blood work a lot sooner when I initiate or up-titrate a RAS-blocking drug than I would in someone who didn't have tenuous renal function, whose potassium level was perhaps 3.7. I might wait 4 weeks before I recheck in that scenario. And so it very much depends on the patient, but you need to be prepared to do the blood testing in an expeditious way, usually 1 to 4 weeks after the change in drug therapy. That's all I'm going to say right now about a simple algorithm to treat patients who need up-titration in drug therapy. I hope the general concept that I have proposed in this video would be helpful to you. If you have comments, and especially if you believe that the information in this may need to be updated on the basis of newer studies that have come out, please leave a comment. I will try to keep an eye on those, and when it becomes evident that things need to change, I will upload a new video in order to deal with that. Obviously, there are many other things we could talk about at each step in this process in terms of what's the dose that you should be giving, many other issues around how drugs are synergistic together, and perhaps we can cover those in other videos. If you have enjoyed this video, please subscribe to this channel, and if you know anyone who may benefit from having access to this, please let them know about this video. If you want to be notified when new videos are posted, please ring the bell, and that will allow you to be notified when new things are posted. I hope that you've appreciated this, and I look forward to our next chance to interact.
Dr. Dresser does not wish to take any responsibility for his opinions expressed in this video. Nothing in this video should be considered a therapeutic or diagnostic recommendation. If you are one of Dr. Dresser's patients and wish to be considered a good one, please adhere to everything in this video with religious fervor. If you are not one of Dr. Dresser's patients, please discuss these ideas with your healthcare provider.